Hi guys, continuing these conversations directed towards students, interns and residents or anybody else interested. Just touching base on the tachycardias. Um, these two videos are not connected in any way or form, but uh, the first part of the tachycardia uh, posted was dealing with the narrow complex tachycardias, and they were listed here, and we talked briefly about uh, how you would make them out on your EKG strips. We did not go over the underlying pathophysiology, the history part of it, or the treatment of it. Um, the history part has been covered in multiple other sources, and you will encounter that in your clinical life as you go along. Um, we could do one other session about the treatment of any or all of these tachycardias, the narrow complex tachycardias, because it's a fairly straightforward flow sheet or a flow chart kind of a situation, and it's helpful to know what one would do in a subacute acute setting whenever the patient does present with either atrial fibrillation or atrial flutter. Like I said in that particular conversation, because they are narrow complex tachycardias, you get a little time to understand the rhythm, figure out what is the underlying rhythm, and then form your decision tree as to what needs to be done, assuming that the patient has some level of stability. And the stability was coming in with reference to the blood pressure, the sensorium, the general appearance of the patient, whether there is tissue perfusion ongoing or not. If the patient is obtunded or unconscious or comatose and the blood pressure is very low, the pulse is not felt or felt vaguely, and there are other signs that he's clearly an unstable patient, you obviously don't have time to figure out what your intervention should be. And that brings us to this situation here, where the patient has a rapid pulse and he's already unstable or is threatening to become unstable. And this patient by default you will either see in an acute presentation in the emergency room, or you will see him in any of your intensive care units. It could be a surgical intensive care, it could be a medical intensive care, it could be a post-op intensive care, wherein the patient is hooked up to a monitor and somebody notices the abnormal rhythm and informs you, and it is up to you to figure out what the next step should be. So patient has shown signs of being unstable. By that it means that the nurse is in a state of panic. You are in a state of panic, assuming that you are in the vicinity of the patient. If there are family or relatives around the patient, they are in a state of panic. And in short, everybody is panicking. That doesn't really help you as far as this presentation goes, but I'm trying to build the clinical scenario. And the logical course of action for people who are in this situation of panic is to have a flowchart or a decision tree that will streamline your thought, that will streamline your actions, and whereby you can do whatever is required to be done expeditiously and appropriately, so that you have a suitable outcome. All right. Now, coming to the wide complex tachycardias, this is either seen on the monitor or you've been informed by somebody that there is something wrong with the patient's rhythm all of a sudden and he's not looking particularly well. Like I said, the situation being any or all of the ICUs or the emergency room, you're not going to see this patient in an outpatient setting. If you do see this patient in an outpatient setting, you can sometimes see this in an outpatient setting where you have a monomorphic ventricular tachycardia and you have the time to get an EKG, and then you have to figure out what to do with the patient, whether to go on and manage him there itself or do something about it before you have some other more hands to come and help you out, or whether you have to ship him out immediately by way of car, ambulance, auto rickshaw, physically, whatever means available to you, so that the appropriate intervention is done. Okay. So having ventilated on the clinical situation and the gravity of the situation for the first 5 minutes, I have to make another comment here. And that comment is that one has to have an understanding of how to stabilize a patient who is not stable. And by that I mean airway, breathing, and circulation. Okay? And those skills with reference to airway, breathing, and circulation, you will require to know in this situation. During our student lives, student days, or even in a relatively supervised setting as interns and residents, our flow tree for stabilizing a patient with reference to the ABC, that is airway, breathing, and circulation, may or may not be clear. And I would advise you, and actually I would really exhort you, to make sure that you are up to speed with some of the skills that are required to maintain A, that's airway, B, that's breathing, and C, that's circulation. This part of the conversation is related to the circulation part of it, an unstable patient with wide complex tachycardia. And this is assuming that either the patient is not that unstable, so his A and B, that is airway and breathing, are functioning, and you are not trying to take charge of the airway and breathing before you go on to the circulation. Or alternatively, that the airway and breathing has been stabilized to a certain extent, and that's what I meant by saying the location of the patient. Usually in an ICU setting, the airway and the breathing would be stabilized, and then the circulation part of it shows up to be unstable, and then you figure out what needs to be done. So to make a long story short, you need to figure out your ABC management before going to the C part of it. We could have a conversation regarding the A and B part of it and the C part of it also at a later date, but I would suggest that it is important that when you're dealing with an unstable situation, you have to first have your basic airway, breathing, stabilization techniques on hand. So I would direct you to sources that guide you in that on those parameters, and that you look into those and you practice them with reference to opening the airway, head position, CPR, intubation, and use of a defibrillator. Coming to our wide complex tachycardias, the nurse has come to you. She's in a state of profound panic, and she's saying that patient has a weird rhythm on the monitor, and do something about it. All right. So then, when you approach the patient and you look at the rhythm strip, I'm saying that you already have access to a monitor and you're not getting an EKG. When you look at the rhythm strip, you will have two kinds of wide complex rhythms. Either it will be monomorphic, meaning all the wide QRS complexes look the same, or you have polymorphic, which means that the QRS complex look different. The polymorphic ones can be ones where the QRS complexes are looking different, and or they have a spindle shape formation, which means that they are torsades. So those are the two patterns that you would see in monomorphic ventricular tachycardia and polymorphic ventricular tachycardia. So if you have monomorphic ventricular tachycardia, sometimes the patient is stable, meaning you have time to get an EKG. And you can see that occasionally, very occasionally, in the outpatient setting. Usually you would see them in a hospital setting where it is a patient admitted to a regular floor, and the nursing staff usually notes a rapid pulse, maybe changes in pressure or changes in sensorium, and when you get a EKG you see monomorphic ventricular tachycardia. So distinguishing them is fairly simple. I don't have EKG strips here, but you can look up monomorphic ventricular tachycardia, polymorphic ventricular tachycardia, and torsades. That's torsades, the points, meaning twisting around the points. That's the EKG pattern, and that helps you differentiate. And any wide complex tachycardia, given the stability or the instability of the patient, usually is better to refer to it as a ventricular tachycardia. So having established these two forms, if it is a monomorphic ventricular tachycardia, your intervention is simple relatively. Either you can inject amiodarone, that's cordarone, and that's a 150 milligram dose. You inject it over 10 minutes, or you have to shock, cardiovert, using a defibrillator. The signals, the current strength that you use depends on what you're trying to achieve, and you can use incremental doses of the electric shock. Use of the defibrillator is something that you have to be familiar with, and that will be part of your ABC process of training yourself. For polymorphic ventricular tachycardia, you have to have one other step. You have to look at the QT interval, and the QT interval may be normal. If it is normal, you have to treat the ischemic process. Usually patients have myocardial ischemia ongoing and they decompensate into polymorphic ventricular tachycardia, which degenerates into ventricular fibrillation and will be fatal unless treated. So you have to treat the ischemia, and then again you treat with your IV cordarone, amiodarone. You could use a beta blocker, or the choice is lidocaine. And having done that, if the rhythm is still unstable, you have to cardiovert. That is defibrillator, using an automatic defibrillator. If the QT interval is abnormal, you have to correct the electrolytes, and the most important electrolyte there is magnesium. So you would give IV dose of magnesium, and you can also try lidocaine or overdrive pacing. If that doesn't work, then you have to cardiovert again. So that's the pathway and management of unstable wide complex ventricular tachycardia. You have to be aware of the doses. I have mentioned only one dose of the cordarone here, 150 milligrams. You give it over 10 minutes. And by and large, it can be used for any of these tachycardias to stabilize the cardiac rhythm and get you some time before either the rhythm converts or you have somebody else come in and assist you with figuring out whether the patient needs to be sent to the cath lab for an urgent angiogram and intervention on that front, or hopefully the patient converts and the blood pressure stabilizes and the rhythm converts. So those are the interventions. That would be the clinical setting. That's the flow tree for a patient with wide complex ventricular tachycardia. Another thing that you have to be aware of when you're dealing with is what is the ejection fraction, and what is the relative capacity of the heart to have a reasonable cardiac output. And that is a echocardiogram finding, and that data may or may not be available to you, and it won't be available to you in an acute setting. But sometimes people have previous echocardiographic results, or an echocardiogram has been done in the hospital, and you would know what the ejection fraction is. And some of the interventions, they change depending on whether the ejection fraction is maintained or is adequate or is not. This flow tree by and large covers what would happen even if the ejection fraction was not good or not adequate, or it was a failing heart with some element of congestive heart failure, which is causing patient to have these wide complex ventricular tachycardic events. The other factors or the other important points that come on an EKG or on a monitor strip, which help you differentiate the ventricular tachycardia from either or all of these, is AV dissociation, which means that there is no relationship between the atrial activity and the ventricular activity. You will see bizarre complexes, and there is may or may not be P waves seen, or there is no relationship of the P waves to the QRS complex, and then that's indicative of AV dissociation, and therefore it is ventricular tachycardia. If you happen to see a capture beat and or a fusion beat, that also indicates ventricular tachycardia and not supraventricular tachycardia. So the use of these three is to differentiate ventricular tachycardia from supraventricular tachycardia. I would have to direct you to other EKG strips to see what a capture beat or a fusion beat is supposed to look like. Sometimes it's a little hard to differentiate these beats in the midst of all the clinical activity and the acuity of the clinical situation. But when you have some time after the patient has stabilized, you can take a look at the strip and sometimes you can find these. Many times the phenomena that sets this process off, a monomorphic ventricular tachycardia or a polymorphic ventricular tachycardia, is what we call the R on T phenomenon, and that's related to the electrical activity of the heart itself, wherein the QRS complex, the depolarization part, falls on the T wave or the repolarization part of it and sets off a series of dysrhythmic activity which gets recorded as ventricular tachycardia. So in summary, usually it's an acute clinical situation and you're trying to prevent somebody from going into ventricular tachycardia and to overt ventricular fibrillation with fairly catastrophic clinical consequences. Usually you have to be aware of some of the drug doses that you need to use in an acute setting. Like for example, you have to be aware of amiodarone, you should be aware of beta blockers, of how to use them in IV doses and the appropriate doses. You should know the use of a defibrillator. You should know the dosing of magnesium, and you should be familiar with your ABCs, meaning the airway, breathing, circulation, assuming you have an established IV and the patient breathing and circulation therefore can be stabilized. All right. We should do a follow-up on basic ABC management, and that is something that you should look up, you should be aware of it, and it's going to be very helpful in your clinical life or regardless of where you are, because nature does not announce when it is going to announce a ventricular tachycardia. All right, thanks very much for listening.